Welcome to The Explainer. Today, we're jumping into the world of gallbladder and biliary tree disorders. Now, if you're a medical trainee, this one's for you. We're going to build a really solid framework for how to think about these conditions, all the way from a simple incidental finding to a full-blown surgical emergency.
So, let's start with a question you will face constantly in your training. You're reviewing an abdominal ultrasound, maybe done for something totally unrelated. And there it is, a gallstone. What do you do? Seriously, this one question is the perfect launch pad for our entire conversation today.
Here's how we're going to tackle this. We'll follow a really logical path. We'll start with that silent, harmless-looking stone. Then, we'll see what happens when it starts to cause problems, leading to inflammation. Then we'll follow it out into the ducts. And finally, we'll cover the big-ticket items, the cancers we're always on the lookout for.
All right, first up, the most common scenario you'll encounter by a long shot. You find a gallstone in a patient who has zero symptoms. This is your bread and butter stuff in medicine and surgery.
So what are we actually looking at here? Well, gallstones are basically hardened little rocks of digestive fluid. Here in the US, about 3/4 of them are cholesterol stones, which form when the bile just has too much cholesterol in it. The other kind, pigment stones, are less common, and you usually see them in patients with other issues like cirrhosis or certain blood disorders.
And this is the classic picture on an ultrasound. See that bright white thing? That's the stone. We call that hyperechoic. And right behind it, see that dark streak? That's called posterior acoustic shadowing. When you see a bright spot with a shadow behind it in the gallbladder, you can be pretty darn sure you're looking at a gallstone. It's a textbook image.
Okay, so here's the most important takeaway for this section. For the vast majority of these asymptomatic stones, you do nothing. You just watch and wait. But, and this is a big but, there are 3 major exceptions where the risk of gallbladder cancer is just too high to ignore. A huge stone bigger than 3 centimeters, something called a porcelain gallbladder where the wall gets calcified, or if you see a polyp in there that's bigger than 1 centimeter. Any of those, and you're thinking about surgery.
Okay, so what happens when that quiet little stone decides to cause a ruckus? That's when the patient gets what they call a gallbladder attack. We call it biliary colic. Biliary colic is really just a plumbing problem. A stone rolls over and temporarily blocks the exit, the cystic duct. Then, the gallbladder squeezes, especially after a fatty meal, and the pressure builds up behind that blockage. That's what causes that awful, intense pain. But here's the key. The stone eventually falls back, the pipe unblocks, and the pain completely goes away. And this right here really nails the change in thinking. The moment a stone causes symptoms, the game is changed. That patient is now way more likely to have bigger problems down the road, like the gallbladder getting infected or the pancreas getting inflamed, and that's exactly why the recommendation flips from watch and wait to let's schedule surgery.
But what if that stone doesn't fall back? What if it gets stuck for good? Well, now that pressure keeps building, the gallbladder wall gets swollen and angry, and you've just graduated from simple colic to acute cholecystitis.
Now, telling these two apart is an absolutely critical skill. So let's look at the clues. In cholecystitis, the pain sticks around. We're talking more than 6 hours. You also start to see the whole body responding. The patient gets a fever, their white blood cell count goes up, and on your physical exam, you might get a positive Murphy sign. That's when the patient yelps and stops breathing in when you press right where their gallbladder is. So, you put the whole picture together to make the diagnosis. You've got the story from the patient, that persistent pain, the fever, and then you confirm it with an ultrasound. You'll see direct signs of inflammation, like a thickened, swollen gallbladder wall, maybe some fluid around it, and you can even do a Murphy sign with the ultrasound probe, which is super specific.
Now here's a curveball you have to know about. You can get cholecystitis without any gallstones. This is called a calculous cholecystitis, and you see it in really sick patients, usually in the ICU. The idea is that their gallbladder just isn't getting enough blood flow, and that leads to inflammation all on its own. It's a tricky diagnosis to make.
And this is what it might look like. In this ultrasound, you can see all the signs of an angry gallbladder. The wall is super thick, there's fluid around it, but look closely. What's missing? No stones. This is a very unhappy gallbladder in a very sick patient.
All right, let's zoom out a bit. So far, everything has been happening inside the gallbladder. But what happens when a stone escapes and gets stuck downstream in the main pipes, the common bile duct? This is where things can get really serious, really fast.
When a stone gets into the common bile duct, we call that choledocholithiosis.
Now it's blocking the main highway for bile to get out of the liver. So bile backs up, the ducts get stretched, and the patient turns yellow. That's your classic painful, obstructive jaundice.
And here you can see the culprit red-handed. This is a picture from an ERCP. The scope is down in the small intestine, shooting dye up into the bile duct. See that round spot where the dye can't get through? That's the stone. And the really cool thing about ERCP is that it's not just for taking pictures. You can actually use that same scope to go in there with a little basket and pull the stone out.
Now, take that blocked up bile, which is just sitting there stagnant, and add bacteria to the mix. What you get is cholangitis. And let me be clear, this is a true medical emergency. You've got an infection in a closed space that's under high pressure. This can make someone septic and kill them very quickly if you don't act fast with antibiotics and, most importantly, get that duct drained.
The classic presentation is something you just have to memorize cold, Charcot's triad. It's fever, jaundice, and right upper quadrant pain. If you ever see those three things together, the alarm bells for cholangitis should be going off in your head and you need to move fast.
All right, for our last section, let's circle all the way back to the beginning, to that incidental finding on an ultrasound, and talk about the thing we're really worried about in the long term, cancer.
So, just like gallstones, you often find gallbladder polyps by accident, and most of the time, they're totally harmless little cholesterol bumps. But some of them can be precancerous, and there's one key feature that helps us figure out who to worry about.
And that feature is size. It really all comes down to size. The number you need to remember is 1 centimeter. 1 centimeter. If a polyp is 1 centimeter or bigger, the risk that it's actually a cancer is significantly higher. And that's an automatic indication to take the gallbladder out, even if the patient feels perfectly fine.
And this is exactly why we're so careful. Biliary cancers are rare, but they are nasty. Gallbladder cancer is the most common of the bunch, and it's often a surprise finding after someone gets their gallbladder out for what they thought were just stones. Cholangiocarcinoma, a cancer in the ducts themselves, is even more rare, but it's notorious for showing up late when there's not much we can do. It just highlights why catching those high-risk signs early is so important.
And all this kind of leaves us with a big question for the future. You know, our imaging is getting better and better every year, which means we're finding more and more of these tiny incidental spots. The real challenge for us moving forward is going to be getting better at figuring out who actually needs an operation versus who we can safely just watch. How do we balance the risks of a major surgery against that small but catastrophic risk of missing a cancer? That's a question we're all still working on.